Good afternoon, everybody. It's good to see that the audience is all still coming in. And we welcome everybody back to the second segment of our series of webinars on physical activity, specifically made for cancer patients. And today I have with me Benson, who's a good friend of mine who basically taught me one word, and there's really only one word I can describe this thing called stability and functional activity, where I myself can learn how to fall without breaking any bones. But we really only have an hour. We could spend several days on this particular topic on falls and functional activity. But what I hope to do and what we hope to do with this particular next 1 hour is to give a little bit of a primer and introduction to what it means to have the risk of falling, and why do cancer patients have a little bit higher risk in falling, and what can we do about it? Is it just about the nutrition, or is it something else that we can focus on? So those who are familiar with me, I have been a medical oncologist for the last 20 years, and I've been with Public Cancer Center for now. This is coming up to the 13th year. For those who don't know me, well, this is my profile. I'm basically a cancer doctor who gives chemotherapy, but my special interest is in breast cancer, female cancers, and particularly in keeping a person active and healthy despite the diagnosis of cancer. So I'm going to share some slides just as a primer, as an introduction to fall and cancer patients. So it's just a few slides on basically falls and cancer survivors and how to prevent. I would label all patients who have ever suffered cancer who is suffering cancer to be a cancer survivor. This is not just limited to individuals who have finished their treatment. It is especially important for individuals with cancer who are still on chemotherapy and surviving chemotherapy. We call them the cancer survivors and cancer warriors. It is important to prevent falls, because once we fall, we become bed-bound, and that has terrible consequences for both the treatment and the prognosis of the cancer. So I'm going to give a quick overview on why do falls happen and debilitation that is associated with the lack thereof physical activity. So the key point here really is that cancer survivors are especially at high risk of falls and resultant injuries. And sometimes the problem with this fall is I can trip and sit down on the floor. That's not really a fall. When we talk about a fall is when we least expect it, when we're walking on slippery roads, when it's raining, when I trip over a carpet that is rolled over, when I trip over my grandkids' toys, when I trip over something that I just dropped, if I had been incontinent or someone else had been incontinent in the house and I slipped and fall in the toilet, all this have very serious consequences. They can include fractures, blood clots, or hematomas. Fear of additional falls, in which case people would just stay in bed or in their chair and further limit their activity. Eventually, in many countries, more so not so much in Singapore, eventually becoming institutionalized in hospitals and getting pneumonias, and unfortunately then passing away, not from the cancer, but from the fall that resulted from the cancer treatment and causing intractable infection. There are some modifiable risk factors. These are risk factors which we can change, but there are also some non-modifiable risk factors. There are some risk factors which we have to accept, and that includes advanced age and advanced cancer stage. This is not mutually exclusive, meaning it doesn't mean that if I'm old and I have cancer, means I can never modify. It basically means if we do have individuals who are in their 90s or their 100s, clearly they're not going to get younger, and it gets increasingly difficult to make them feel or act younger. Advanced cancer staging, yes, we do have patients who present to us when they have very debilitating stage 4 cancer, for which, because it's riddled in the bones, they are unable to move around. So that's unmodifiable risk factors. there are a lot of modifiable risk factors: poor physical function, poor cognitive function. In layman terms, just means mild dementia, forgetfulness, impaired balance, gait, use of certain types of medication, and what is not written here, but also very importantly, poor eyesight and poor hearing. Sometimes we rely on not just our eyesight to look at what's in front of us, we also hear things. We can hear the car go by and hear the moped, the bicycles go past us. If we are not aware and we're not able to see the car, or we're not able to see the bike, we can rely on our hearing. But if we cannot see and we cannot hear and it suddenly appears in front of us, we got to learn how to be able to be stable so that we don't end up creating a fall for ourselves. So there are many opportunities for rehabilitation to intervene to decrease the risk of falls. I would like to just introduce the audience into this particular concept called the performance status. It is a term that physicians are very used to. There are two. One of the older scores, we call it the Karnofsky performance status, and the other one that we're more used to, we call ECOG or WHO score. Simply put, it is a scoring that we can predict what happens or what is the likelihood of a patient who would respond well and tolerate the chemotherapy treatment or the radiation treatment or even surgical treatment that we're about to recommend for a patient. The better the ECOG score or the Karnofsky score, the better the patient would do in terms of receiving chemotherapy, radiation, and the outcome of surgery would be more successful. So if you can look at this scale here, basically it goes from 0 to 5 or 100 to 0. So fully active, able to carry on pre-disease performance without restriction. But of course, we need to focus on this called pre-morbid or pre-disease performance status. The lower the pre-disease and pre-performance status, the lower the subsequent cancer-related mobility and performance status it will be. And eventually it goes from a score of 0 all the way to 4, which is completely disabled, cannot carry on self-care, totally confined to bed or chair. When we see a patient who has got an ECOG score of 4, we normally would say that they are unable to tolerate treatment. Perhaps they will get a lot of side effects from the chemotherapy. So sometimes we steer away from chemotherapy. And I would dare say that sometimes that's basically a little bit of a bias because we don't really want to give our patients more harm than the cancer already has. Of course, the truth is that many a times this is acutely due to the cancer, and we treat the cancer decreases, they get more active, and they go from ECOG 4 all the way back to ECOG 0 where they become fully active. But we don't take this for granted. Every month that we spend being in bed, our bones and our muscles would degenerate. So these are some of the studies to look at the feasibility at targeting patients with cancer with poor ECOG status. I'd just like to share this very simple study of looking at step counter. Many people look at physical activity and they are daunted. No, I cannot go to the gym. The gym is a dirty place. I don't want to get infection there. I don't have a gym at home. I don't have a gym in my condo. I don't live in a condo. I live in a, it's too crowded. I can't, and it's too hot to go outside. But we forget this simple thing, means walking around. According to a 2017 study, Singaporeans walk an average of 5,674 steps a day for a sedentary office employee, meaning they go to the office, they come home, they take the public transport. This is the average that they walk, 5,674. The HPB, our Health Promotion Board, promotes an average of 10,000 steps a day. Some of us physicians believe that it should be as high as 15,000 steps a day. Of course, sometimes we cheat. The shorter we are, the smaller the steps, the higher we do. The taller we are, the less steps that we do. So it's very arbitrary. But basically, this study that was published very recently in 2020 March in JAMA, a very well-known medical article, shows that if we go anything from 4,000 to 8,000 steps a day, we may be able to reduce our risk of death from heart diseases or cancer by as much as 2/3. Basically, that's it. Without looking at anything else, without having a specialized gym or a trainer that trains, all we are able to do is to do that 4,000 to 8,000 steps per day. But in order to get to 4,000 to 8,000 steps per day, it actually means that we're fit enough to do this. So it is not that I try my very best, I kill myself trying to do 8,000 steps per day, knowing that I can reduce my risk of death. It is more so if I generally are able to have a physical activity up to 8,000 steps a day, feeling comfortable, this tells me I already fall into the group whom I'm going to survive well. So why not walk? As I mentioned just now, it could be a history of falling. I feel like I'm going to fall. Many patients who are on chemotherapy, they have this problem called neuropathy, where they have pins and needles in their fingers, they have numbness in their feet due to the chemotherapy, or their pre-existing condition with diabetes or OH-related neuropathy or changes or decrease in the nerve sensation. So when they step on the ground, they feel like they're stepping on cotton wool. They can't really feel the floor. So they feel like they're going to fall. That results in poor coordination. And of course, then eventually they just end up sitting around or going around in wheelchair. Again, just now I mentioned there could be changes in vision, changes in mood, fear, memory, confusion, hearing problems, or coordination. Some of them may have small strokes and all that leads to the risk or not of wanting to work. There could be bowel and bladder problems, meaning because of the severe diarrhea, or they feel constipated because and resulting in backache, they end up not wanting to walk. And of course, all we know, the environmental risk around the home. Clutter, dim lights, pets, they may be a tripping hazards, uneven floors, or even stairs. So all this is important. So when we have an individual who's older, who's debilitated by chemotherapy or by cancer, it will be useful to actually give them a clean room, lack of clutter, bright lights, a toilet that is en suite, and if possible, on the ground floor so that they can walk around without having to worry about reaching upstairs. Many patients who live upstairs on the second floor or the third floor just end up staying upstairs and never coming out of the house at all. So cancer and falls, specific for cancer patients, they could be anemic, they could have low blood count, low immune system, they could feel really tired, they could have this thing called postural hypotension, where if I lie down, my blood pressure is correct, but when I stand up, because of the nerve problems, it becomes really low and I feel giddy and I faint. Muscle stiffness and pain due to chemotherapy, and water retention leading to joint aches. But generally speaking, we do see that many of our cancer patients, despite finishing chemotherapy, they will complain of muscle stiffness. And unfortunately, one of the reasons for muscle stiffness is the lack thereof physical activity. So for the individuals who keep active, they continue to walk, they continue to run, do Pilates, yoga, Tai Chi, they will not complain about the muscle stiffness so much. In fact, once they've done their 15 minutes exercise in the morning, they feel like the top of the world and they don't have this muscle stiffness, and chemotherapy becomes much more tolerable. I want to introduce a concept again called Sarcopenia and Cancer. And there will be another webinar that is specific for sarcopenia and how we build muscles and gain weight, the good weight, not fat weight in patients. We look at a very simple weight. When we see a patient, we will weigh the patient and we will look at the height and weight and we calculate the chemotherapy based on that. Unfortunately, the weight will measure both fat and muscles. But if I have an individual who's lightweight or heavyweight, but mostly fat, that is a very dangerous sign of an increased risk of dying from the cancer. But if I have a very heavy patient who's full of muscles and very low fat, he's basically strong. So I want to introduce this thing called, do we have enough muscles in our body to protect ourselves and to enable the function of our bones and walking around and the activities of daily living? So there are many reasons for muscle loss or sarcopenia. Sarco just means muscle, penia just means lack thereof. So sarcopenia, aging, genetic predisposition, comorbidities such as diabetes, heart problems, reduced physical activities, and of course for men, specifically decline in anabolic hormones when they age and they lose testosterone. Treatment-related chemotherapy, surgery, radiation, of course, it's always easy to blame it on the oncologist. And I'd say that I would blame it on myself too if I don't give my patients enough education about nutrition and physical activity to keep sarcopenia away. So we must look at this whole thing here. Food, nutrition, obesity, physical activity, and cellular processes that are linked to cancer. Specifically, we look at food, nutrition, obesity, and physical activity. We always say eat well and lose weight because we don't want obesity, but we don't want our patients to lose muscle. They must improve on muscle activation. All human beings have the same number of muscles. I have the same number of muscles as a baby, but the function and the muscle volume is different. So when we say we have lost muscle mass, I don't have as much muscle as Benson, but it just means that I don't have as big a muscle as Benson. I'm not as strong as Benson, but I have the same number of muscles as Benson. So I just need to train them up. Someone asked this question just now, how much protein do I have to have? Should I increase and I eat a high protein diet in order to increase the amount of muscle that I'm building? We are looking at cancer patients who are generally rather sedentary. They do some activity, but they are not training to be strength athletes, bodybuilders, or endurance athletes. But there's a very simple graph here where the protein requirement for an individual who's fighting cancer should be anything from 1 gram to 1.6 grams per kilo per day. So if I'm a 50 kilo person, all I need is about 50 grams, so maybe about 80 grams of protein a day, and 2 slices of normal gardenia low-carb bread will give me already 10 grams. 1 egg will already give me 6, so that's 16 already for breakfast. The problem with many breast cancer patients is that we eat way too much protein and we end up causing obesity. So it is actually very difficult to eat too little protein. But if we begin to eat too much protein, that gives a lot of stress to our kidneys and to our liver. So the current RDA, or recommended daily allowance, is approximately 1 to 1.6 grams per kilo. Once we go up to 1.5, up to 1.8, even for an endurance and a strength athlete, it doesn't increase the muscle synthetic rate. So to ask my patient to drink liters and liters of protein powder, it's just going to stress their kidneys. It doesn't help. So we only advocate protein supplements if a patient is unable to chew or take in solid, good animal protein, or eat enough tolerate plant-based proteins such as beans. So the protein requirement actually is very little. So if we look at the caloric intake, there's a simple formula here. We look at our amount of calories that we need a day. We need the amount of protein. We need the fat for function of our nerves and our brain. We cannot eat a completely low-fat diet. Then the rest of it is carbohydrate. If I reach my caloric intake with protein and fat and I don't need carbohydrate, is that ever possible? For the Atkins diet or the high protein diet, that's never possible. But if I'm very physically active, I can afford to eat more carbohydrate. But if I'm not, I will cut down. So then the rest of it is it. If I'm eating enough protein, I need all this training in order to make my muscles do what it needs to do and take up the substrate that I've eaten. Without all this coordination, resistance, endurance, balance training, then basically whatever protein I've eaten will come through my kidneys and get passed out into the toilet. So it's all wasted. So with that, I'm going to hand over to Benson